All right, now we get to the controversy. So, Mike, what's the time of onset for succinylcholine? Yeah, it's a little faster. So IV, it's 30 to 60 seconds. Has anyone used it IM before? Yeah? Tell me your story.
When I was a resident at the University of Pennsylvania, pre-EZIO, for some of the really large, rowdy, aggressive trauma patients, they would, who if you had no IV access on, they would sort of simultaneously get like IM ketamine and IM sucks at the same time, and at some point they would sort of collapse and they'd be both sleepy and paralyzed at some point on the bed in a few minutes.
So that is exactly the same situation I had. I had this this huge guy that was high on methamphetamine and just showering with sweat. I mean, literally the sweat was pouring off him, and we tried to start an IV. Stick your arm out, Chris, and like literally you just slide off of him and he'd move, and it was just like a greased watermelon. And he was hypoxic. His face was blue, his lips were blue, and he's just this big giant, and he's throwing us around. And so finally I just ran up and jabbed him with the succinylcholine, and we backed up and we all watched. And then he went down and we all ran in and intubated him, started me. But it was also before the EZIO. Okay, and how long does sucks last, Seth? 5 minutes? Okay, yeah, so 4 to 5 minutes. Okay, rocuronium. Chris, how long does it take for rock to take effect?
60 seconds.
60 seconds, good. And there's not an IM, sorry, so this one thing about IM sucks, it lasts a long time. So rock onset about 60 seconds. How long does it last, LA?
30 minutes.
Yeah, 30 minutes. So quite a difference, 5 minutes versus, maybe 45 minutes. And so again, let's go back to talking about why is longer paralysis safer? Why are we telling you that you should never use succinylcholine again in your practice in emergency medicine? And we'll talk more about the adverse effects of sucks in a second. Again, so we know that our best possible conditions are when they're paralyzed. So we want to use a paralytic. There's no doubt about it. But again, so part of this is we have this fixed false belief in emergency medicine that, well, if we intubate, if we paralyze them and we can't get the tube, they will rise back up and they will come, back up to normal and they'll be okay. And I can't believe that I bought into that as well, because there's a reason why we decided to paralyze them and intubate them. And now we've run a metal spoon in and out of their mouth a few times, and we've shoved things in and out, and we filled up their belly with air. And now we think that we're just going to let it wear off and they're going to be okay. I mean, to me that sounds crazy. And again, so what do we do if we can't get the tube? We bag them. We want them paralyzed for bagging. What do we do for our rescue device? We want to use an LMA or King LTD. We want them paralyzed. So the safest thing for the patient and the best chance we have of managing their airway is for them to stay paralyzed and not be waking up on us. Can you repeat the dose of sucks? Sure. But is that what you want to be doing when you're in the middle of a difficult airway, is drawing up more meds and giving more drugs and trying to fight every 5 minutes the patient waking up? No. You want them out for 30 minutes plus to be able to bag them effectively and use your rescue devices. So, comments on that? I know this is a dramatic departure for many of you that have grown up on succinylcholine. Okay, so we want a longer acting paralytic to make the safest possible environment for not only intubating, but if we get in trouble, for using the bag valve mask or the supraglottic devices.
Jesse, is there any new evidence about this, or is this just sort of expert thought, having reconsidered all these factors? Because nothing so far that you've presented is new data from 10, 15 years ago. So
good point.
Is there something new, or is it just more evolved thought with the same information?
So it's more evolved thought with the same information and expert consensus, but the kicker is what I'm going to present now, and that's the side effects of succinylcholine. Part of the finesse of using a longer-acting paralytic is to have your sedation ready and know that the patient isn't going to be waking up and pulling their tube out, which was always troublesome before, because often we weren't really good about either ordering it or the nurses getting that ready to administer.